Yeah, the more we do things, the better we get at them. And it's number one, helping the patients. Number two, it's super rewarding. I mean, tell me somebody who hasn't said, boy, it's been very rewarding to do something and improve on it and get better and better at it. I mean, they call this the practice of optometry, the practice of medicine for a reason. So yeah, I look at eyelid lesions differently today than I did 15 years ago because you do something so much, and when you're doing procedures, and there's a different appreciation for the anatomy and the physiology and all that good stuff, and it just adds to your knowledge base and your experience base, and it ultimately, at the end of the day, it provides better patient care for the next patient and the next patient and the next patient, the more experience that you have and the more that you do.
Hello and welcome to the Crystal Podcast on iCode Media. Today I had a great conversation with my good friends, Dr. John McCall and Dr. Nate Lighthizer, and we talked about the AAOMS. I'm not going to tell you exactly what that means. I want you to listen to the episode to find out. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. My patients with macular degeneration want clear and succinct recommendations from me related to products and solutions that can benefit their long-term ocular health and vision. To do this for my patients, I need to be confident that what I'm recommending will have a benefit to them. And that's why my supplement of choice is MacuHealth. MacuHealth is specifically formulated and clinically proven to rebuild and maximize macular pigment over a lifetime. This results in enhanced visual performance and aids in the treatment and prevention of age-related macular degeneration. I've discussed carotenoid absorption on this podcast with Dr. Nolans and Stringham, and MacuHealth uses a patented process called micromicelle technology. And this technology is clinically proven to increase carotenoid concentrations at the target tissue and deliver the highest level of bioavailability studied to date. MacuHealth has been great for my patients. We really feel like we have the ability to help those patients in all categories of macular degeneration. If you're not utilizing MacuHealth for your patients, check it out for yourself by contacting your MacuHealth representative. Young and emerging presbyopes can be tricky. These patients want and need additional help at near, but they can be resistant to solutions that create even mild distance blur. The MyDay multifocal lens has been great for our presbyopic patients. It allows those patients to transition into a multifocal more easily. We've had this lens now for long enough that we've been able to see how simple transitions can be from an adaptation standpoint from lower ad designs to higher ad designs. The MyDay multifocal material is CooperVision's softest one-day hydrogel lens and features Aquaform technology combining the unique balance of high oxygen permeability with natural wettability in one material. The result is a highly breathable lens that keeps our patients' eyes looking clear, white, and healthy. So if you haven't started utilizing MyDay multifocal in your practice, I'd encourage you to reach out to your CooperVision representative to get started. And, one of the reasons that I wanted to have you guys on is to talk about just the idea of, surgical privileges within optometry, surgical excellence within optometry. And then also, I'd like to start off by discussing kind of the ACGME minimums for ophthalmology. So a lot of times we think in the profession that, we don't like to have minimums in law or minimums in statute. And I agree. I don't like to have that either. But when you look at the minimum number of surgical procedures that the ACGME, what's that? The Accreditation Council on Graduate Medical Education requires for ophthalmology, it is staggeringly low. And ophthalmology doesn't like to talk about that. So I can share this with everybody, but Nate or John, off the top of your mind, have you, do you know what those numbers are?
You could look at our numbers and basically subtract one, and you'll know exactly what they are. But Nate,
So
correct
you
me if
do
I'm
know
wrong,
those
but
numbers.
I do know those numbers. It was like what five? I'm thinking five
I'm putting them up
SLTs,
right now
five
on the screen.
YAGs.
So
Okay.
Yeah, it
Yep.
depends on the procedure. Depends on the procedure you're talking about. But generally speaking, for the procedures that optometry is doing, that the laser procedures, the Chalazions, when you look at the ophthalmology numbers for when they exit residency, it's somewhere between about 3 and 6, depending on the procedure that you do. Last I checked, I thought capsulotomy was 5, and SLT was 5, and maybe iridotomy was 4. Maybe chalazion was 3. I'm not even sure if chalazion was on there, but obviously they have minimums for cataract surgery. That's going to be the main one, and other things. But for the procedures, that are equivalent to what we're doing, it's somewhere between like 3 and 6.
Yeah.
Yeah,
Yeah.
and
So
and
I've
it
got them pulled up for the listeners who can also watch right now. So actually for the people who can't see the screen, I've got the ACGME minimums pulled up right now, and YAG capsulotomy. The S next to it means they're the primary surgeon. That's 5. Laser trabeculoplasty. The S means obviously primary surgeon, 5, and then iridotomy is 4. So yeah, you're absolutely right, Nate. Not as many as you'd think. And then when you actually look at what the outcomes are, which I believe I have in this report as well, is there's another report. I'm gonna have to pull that up. But in any case, I can't know exactly how this works, but there are some who graduate or finish their residency and don't meet these minimums. So I'm not sure what they have to do, but if you look at the report of the actual outcomes, there are ophthalmologists that finish with actually like 1 or 2, laser trabeculoplasties during their ophthalmology residency. So what's your take home
yeah.
from that, John?
Well, it just what you stated, Chris. It's amazingly low, and those of us that have had the opportunity. I'm in East Texas. Obviously, Texas is not a surgical state, but Louisiana is, and I'm not that far from Louisiana. So I went up there and got some beautiful instruction at Italiquah with Nate. He's my primary instructor there, and then came down and started doing these procedures. And then, as I testified during the legislature, as a lot of us have, and then I guess the epiphany moment was when I saw Newsom. California did a wonderful job passing a surgery bill, and then it got vetoed. And Governor Newsom said, "Well, it's because I just don't think optometry has the training that ophthalmology has." So that got me thinking. I said, "What is their training?" And I went to look it up, and I went, "Seriously, this is all it is? Why don't we come up with a measure of excellence that's above that?" And that we kind of started the whole thing. And I called my partner, and I called Nate, and we kind of took it from there. And that's the way this academy kind of was formed, and it's still going through a little bit of a maturation process. But we're real pleased with the where we are right now and what it will stand for.
To me, it shows how optometry is so very capable and so very qualified. And you'll hear ophthalmology, specifically political ophthalmology, mentioning 17,000 hours of training and all these surgical cases. But when push comes to shove, the procedures that optometry is pushing for, YAG capsulotomies and SLTs and laser PIs and injections of lidocaine into the eyelid and eyelid procedures, again, the number is between 3 and 5, 3 and 6 for these. And optometry is incredibly well qualified. I mean, during my residency, I did between 60 and 70 laser procedures, so I far exceeded that. I was testifying in New Hampshire a while back, and one of the ophthalmology residents on the other side said that he did 25 lasers during his residency. Well, I'm like, oh, I got more training during my residency on lasers than you did. So I think the take home point is just that it's not hundreds and hundreds and hundreds of procedures, and that optometry is incredibly well qualified to perform these procedures, should they so desire. We're a very broad profession. We all know we have some people that are just contact lens experts and low vision experts and vision therapy experts, and we have experts like John McCall that are laser procedure experts and injections, et cetera, and just recognizing the excellence of optometry that we are.
Yeah, and I think you and I have talked about the data just in terms of utilization, and in Nebraska, we're not a huge state, but we hear all the time there's plenty of ophthalmologists that can serve the need. And I just searched, and I'm going to share this screen actually with everybody. So if there's a data pool that I like to search to get information about what is actually happening in our profession and other professions. And so I just quickly searched Nebraska data, and now it's got to reload. Nope, that's not it. So I just quickly searched Nebraska data, and what I found was basically in all of Nebraska, there's about 16 ophthalmologists that have billed any SLTs, 16 in the whole state. And the vast majority of them bill almost no SLTs. And I think, you're going to see obviously higher amounts with, we're going to see higher amounts when it comes to, YAG capsulotomies, but the bottom line is that they're just not doing that many. So here's, I'm going to share this. So what's been your experience then, John, in terms of your local community when you're moving people from one place to the next in order to meet their needs? How do they respond? Like, I can have this done in Louisiana, but I can't have this done in Texas.
Basically, I always jokingly say there's three kind of practices in the United States. There's urban, rural, and then the wilderness America, where I happen to be. So all of my patients for the last 35, 40 years have been going to the best cataract group, who are good friends of mine, is 60 miles away. Well, I'm about 20 miles further to Louisiana. If they'll drive 60 miles to get cataract surgery, they'll drive another half hour to see me. And when I explain to them that we're going to do a procedure that, especially with my patients, that I hold the method patent on, that they have a lot of confidence. So I would say this is starting my 10th year of doing surgery this year. And in 10 years, I've probably had 3 that said, I can't go to Louisiana. The other obstacle is Medicaid, because it's crossing state lines, and that doesn't work on that. But it really hasn't been a problem. I mean, patients will go where patients are comfortable going and who they have faith in.
Nate, when you think about the need for additional recognition in by performing some of these cases, what do you think that says to our profession? Other providers in the profession, and what do you think it says to the public about the differences between optometrists? Is that confusing to people? Does it clarify? What's one of the goals of this?
Yeah, I think one of the goals is just to recognize excellence for what optometry is. I would hope the answer would be the same for both of them. It is a feather in the cap to optometry and the provider, and that just because I am not a contact lens expert and don't hold some of those contact lens fellowships doesn't mean I'm not less of an optometrist. I'm still, a pretty good optometrist, and we have such a broad things that we do. So I would like to think that, number one, for the public, it is going to be an extreme compliment for anybody who is a fellow of the American Academy of Optometric Medicine and Surgery and holds an AAOMS, that it's a big feather in their cap, but it's also a feather in the cap of optometry going, look at the excellence of the providers that we have in this area. So I think the public would view this extremely positively. And I would like to hope that optometry would as well. I look on very high regards to people like my wife that does no lasers and no injections, but is a contact lens expert and has all kinds of qualifications in that, or maybe it's low vision, or maybe it's the vision therapy, whatever it is even our colleagues who go, man, look at what cool things our colleagues and friends are doing in their arena, and you do your cool thing in your arena. So I would like to hope and think that it would be looked at positively by both patients and our colleagues. It's not a threat. It's not making me any better or worse than anybody else. It's just recognizing the excellence that a provider has exhibited in this particular area. And it's a feather in the cap for that provider and to me for all of optometry. So.
I mean, the classic analog to this would be COVD, right? Nobody gets mad about. I mean, that's definitely a subspecialty. It's because I could see that fellowship in American Academy of Optometry (FAAO) it's kind of open to all. You can achieve it by a number of different paths. So I could see why it's not exactly the same. I mean, I agree with you, Nate. I don't think it's necessarily dramatically different enough, but I think some could make the case that, well, it's not exactly the same because it's a subspecialty. But with COVD, we don't have a lot of people running around concerned that we have a different class of optometrists that have that as you determine, or as you describe, a feather in the cap. So, John, is there any concern that this turns into board certification 1.0 and board certification 2.0?
No, as you know, I have been there, done that on both of those, and that's why we stayed away from the word certification. And a bit early, we were using the word credentialing, and now we're moving away from that because it's more like what Nate said, and that is we just want to recognize excellence in care. In this care, it happens to be surgery care. And just so I can be crystal clear about this, I mentioned testifying in front of the legislature here in Texas. I did the lead testimony on that, and then listening to Newsom say when he vetoed that we didn't have the training. That got me to thinking about having a level of excellence. But this is not to help states pass legislation. That falls on AOA, State Government Relations Committee. They are the ones that the state should reach out to. But as we go forward, we have, roughly, depending on how you want to count them, around 12 states now that have surgery. Well, that's going to soon go to a lot more. And the reason it's going to do that is because the demographics of this country. Just if you look at how many ophthalmologists are going to be here in 10 years and how many optometrists we're going to have, they simply cannot keep up. It's not possible.
Yeah. I mean, it is. And I think about, the Midwest in particular, I'm very optimistic about a number of states in the Midwest. And as I know, Nate, you are as well, John, you are as well, is that, I think we're very close to that tipping point. And then there is something that is nice about proving or showing or going through a specified process. It even just within your professional self of being like, yeah, I thought that was hard, that was challenging. I had to talk about why I did what I did and articulate the nuances of complications potentially and how I managed those complications or how I prevented those complications. I remember walking away. I mean, I've had my fellowship now for probably 14 years. And I remember walking away at that time and feeling like, wow, I've got this, and it wasn't that it was so hard or it was really grilling, but, diving deep into whatever the thing is that you're doing and then defending that, there's a lot to be said with it. The same thing with board certification is it's like, well, I had been out of school just enough time to wonder, do I really understand this stuff? And I'll tell you that that the maintenance over time has been really helpful for me to make sure, like, the maintenance of certification. I know we're not talking about board certification here, but the maintenance of certification in my mind has been really valuable because it is a touch point that I have to prove that I'm not only just reading stuff, but I'm retaining it for long enough to answer questions that are actually like dig a little bit deeper as far as applying things. And so, I know this isn't certification, but if you have some sort of those things built into a program like that, it does help the doctor, one, be confident that they've been able to prove to somebody else that they have achieved a certain level of knowledge, education, and training, demonstrated that they can understand and assimilate information and have a back and forth conversation about it. And then making sure that they stay up to date on those new technologies. Nate, I'd love to hear your thoughts about this, but there's a new company now that has a direct SLT. So what's that going to do to the level of care and the simplicity of the care? It's going to be more about, am I identifying the best candidates? Am I kind of titrating my post-operative expectations and treatments to maximize those the effect of that SLT specifically? There's just new technology like that comes along that could continually be assessed by an organization such as the one you're talking about.
Yeah, I completely agree. And, going back to your previous point, and then I'll get into direct SLT just a bit, but, think of how proud you two were when you graduated optometry school, an accomplishment that what you did, you got through optometry school. And then, think of how proud many people are when they finish residency. We can go through optometry school, many did a residency, but not all. Think of how proud those people are when they get that fellowship in COVD, that fellowship in FAAO, as you said. Those are proud moments, and they add to us as individuals, and they add to us as a profession as well. So you are completely correct on that. You are so spot on of when you achieve something like this, there is a sense of professional accomplishment and a sense of professional pride. And I think that is extremely important. And technology evolves and advances all the time. SLT has evolved tremendously. We've talked about it on this podcast before and in many other arenas. It's best utilized first line therapy. And yeah, direct SLT was approved in December, and it'll be definitely a disruptor in the space. And I'm not saying that in a negative sense or a positive sense. It's going to be different, and see how this comes about. And it hasn't been rolled out yet, but if you take a procedure that we know eases the burden on patients so they don't have to take those drops all the time, and now this procedure can be done much, much more efficiently and without a lens on the eye, and it's partly automated, it's going to be interesting and fun to see where it goes in this space, because the literature is pretty clear now from the light study, the SLT med study, but the light study was the biggest one. Patients do better with SLT compared to drops. They're more likely to progress on drops. So, it's just interesting. As technology evolves and advances, we have to stay up to date. I mean, think about it this way. It is an absolute fact that optometry looks different in 2024 than it did in, let's pick a number, 1990. 34 years ago, which isn't that long ago, optometry looks much different. What are we going to look like 34 years from now in 2058? And I don't think, if those doctors knew what it looked like today from 34 years ago, I'm not sure they would believe it. And I'm not sure we would believe it today if we said, all right, snapshot, this is what it's going to look like 34 years from now. I'm not sure we would believe it, because things evolve and they advance.
Yeah. Yeah. I mean, well, this is just kind of a side note. But since you guys run a lot of studies, I haven't seen one, and I haven't asked the question of the literature yet, but off the top of your head, do either of you have any data to understand how patients perceive their disease state when they're having to use a medication every single day versus having to check in with you, two to four times a year to see how their pressure is? And like, do they actually perceive it as less of a burden on their lifestyle? I mean, obviously, like, less of a treatment burden, but like, just in general, do they perceive their quality of life to be better? I haven't seen any studies on that. My suspicion is that it would be, because they're not thinking of it all the time.
And I think it depends on, Chris, the patient and the number of medications being used. And it's not just now. I don't think of it as, are you putting 2 drops in your eyes or 3 drops in your eyes, because we have so many combination drops now. If you're putting 3 drops in your eyes, you could be using 5 medications. And what we found out is that over time, you can with the preservatives in these drops, you can damage the trabecular meshwork. So you have to look at glaucoma as a long-term therapy treatment. Where is this patient going to be 25 years from now? Are they going to be at a stage, because I can say this from experience, because my mother's 97 and my dad diagnosed her glaucoma when he was halfway through optometry school back in the late 40s. She's had glaucoma longer than most people have been alive. She's had a couple of trabs. They've already failed with age, and now I've got her on maximum medical therapy. But the problem is, not much works on her anymore. And so the longer, my theory, my personal opinion, the longer you can go and keep the patient off of drops or on less drops, the better that patient's going to last 10, 20 years from now in this disease state.
Yeah, I'm right there with you, John. I think even if so let's say you can repeat SLT 3 times, and maybe even just take it down to 2 times, right? And you can be confident it's going to work twice. And the lowest level, you're going to expect it to work once it works in that 80% group, that it's going to work for, let's say, 3 years. But on the highest level, you could expect 5 years. So you get at minimum, you're thinking a 6 to 10 year window that you get to push that patient's life out without having to have another medication. And certainly a 6 year window based on the light data, that's pretty powerful, really, when you think about it. So I think this is, when I talk, Nate, you and I have discussed this before, but when I talk about the impact of patients' quality of life and access to care, SLT in my mind it's a much more compelling story than YAG. And yet most optometrists think of YAGs as like, I want to get YAGs, but I don't know. I look at glaucoma and I think, for the same reasons, John, you're talking about, is you never really know how good you are at managing glaucoma until you're probably as long as, 15 years in practice like Nate and I. And certainly we know how good you are by the time you've been in practice that long, John, right? So like you never can really identify, like, was I good at treating glaucoma? It takes so long to know how well you are, based on how your patients are progressing, that it just starts to become clear at maybe year 10, 11, 12 about what you're doing and what your philosophy is and how that's impacting patients. And I just think, I believe that SLT technology and probably others are going to be so minimally invasive, so effective at delaying medication treatments and all the things that it does to our ocular surface. I've mentioned on the podcast, maybe I've definitely mentioned in public, that the new clinical practice guidelines on glaucoma from the American Optometric Association have a pretty strong statement that is essentially like a should. It's something like patients who are on glaucoma medications should be evaluated for ocular surface disease, which to me is like, that's an astounding statement. I mean, it's intuitive to all of us, but it's a very powerful statement on how seriously we should take the side effects of these medications.
And a good point you're making there, Chris, is the reason that optometry has embraced this. If you think about it, before this, if you referred a patient to somebody for SLT and they came back and you didn't get a good result, what do you say to that patient? Whereas if you did the procedure yourself, you know that maybe that patient was a little jumpy, maybe you had to calm down, maybe you got in there and it was one angle was a little bit more closed than you thought, so you could only do a 270, so you jot that down. I was only able to get about 270 degrees on here. This patient may need an LPI in the future. All those things you'll know about when you're treating, whereas if you refer it out and they come back and the patient's looking at you, well, I'm right back where I was, and you have no knowledge of, was that a difficult procedure? Did the ophthalmologist decide I'm in a hurry and the patient's jumpy and I'm just going to do the minimum amount and get out of here because I get paid the same? Not that anybody would do that, but you don't know. You just don't know because you wasn't there. So my treatment and my success rate has gone way, way up because I'm the one that did the procedure. And I take a lot of pride in that. And when they come back, I know what to look for.
The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out eyecodeeducation.com. One of the challenging things with patients is when they invest in a really high quality pair of glasses and customized lenses, it can be challenging to keep those lenses clean, keep them scratch free, smudge free. And so we now have the ability with Crizal Sapphire HR lenses to offer our patients the best in class anti-reflective coating in a way that is really high resistance so that they're not having to care for their lenses as much as when those lenses are caring for them. So remember that you can provide patients that best in quality, best in class transparency, clarity, durability, and UV protection in a single Crizal coating. If you want to learn more about Crizal Sapphire HR, contact your Essilor account executive or visit essilorpro.com/Crizal. Yeah, it's a good point. It also, and Nate, you can comment on this as well, but I think that point, John, kind of articulates the idea of the more expert you become in one specific area. And this is, Nate, we're talking about SLTs, but, I would guess that the way that you look at an eyelid lesion is, I've read all the books. I've removed tons of lesions when I was in school, but the way you look at an eyelid lesion and the margins of an eyelid is just dramatically different than the way I look at it now, because you're so used to thinking about all these other things that just don't matter as much in what I'm in clinic, because I can't remove those lesions. And so, I can tell you for sure that, the way I look at my Boehmian gland structure and function and other anatomy around the eyelid is dramatically different than the vast majority of optometrists who don't look at that all the time. And so to your point, John, it's like, you're thinking on all of those different things becomes deeper and more nuanced and more complex. And that will not just serve your patients who had an SLT, but it'll serve your patients who just need gonioscopy or who just need, some other aspect of their care that you've just been able to understand more about and look at the nuance there differently. And it translates into better care.
Yeah, the more we do things, the better we get at them. And it's number one, helping the patients. Number two, it's super rewarding. I mean, tell me somebody who hasn't said, boy, it's been very rewarding to do something and improve on it and getting better and better at it. I mean, they call this the practice of optometry, the practice of medicine for a reason. So yeah, I look at eyelid lesions differently today than I did 15 years ago because, you do something so much. And when you're doing procedures and there's a different appreciation for the anatomy and the physiology and all that good stuff. And it just adds to your knowledge base and your experience base. And it ultimately, at the end of the day, it provides better patient care for the next patient and the next patient and the next patient, the more experience that you have and the more that you do.
No, I agree. And when you're following your own
ahead, John.
outcomes, how much millijoules of energy you use for the various pigment and, without going into depth on there, obviously if you've got a lot of pigment, deeply pigmented, it takes much less millijoules of energy in there. And my philosophy over the last 10 years has changed. I use much less millijoules of energy. I get a reaction, but I used to want a reaction on every time I shot the laser. Now, if I get every third or fourth, I know I'm getting a reaction to the tissue. So your knowledge, if you're doing the procedure and you're following the outcomes, your knowledge of how much millijoule, how much energy to use in different situations gets better and better. So I would just tell you, I'm a lot better now than I was 5 years ago, and I thought I was pretty good 5 years ago.
Yeah,
And
that's the
guess
fun,
what?
I mean,
The
that's the
same
fun
is
part. In
true
today's
for
point, that's the practice.
And the same is true for ophthalmologists, for our brain surgeons, for our heart surgeons, for our primary care physicians, for our dentists. We all get better. The same is true for Patrick Mahomes here on Super Bowl weekend. Now that he's 7 years into his career, rather than less than that.
Mm-hmm. Yeah. So listen, that I'm going to take that as needing to be respectful of your time. But here's what I want to do is I want to project forward. In your mind, I'm not asking you to lay out what this new organization is going to have in terms of qualifications and requirements, because I know that's still in flux. But in a perfect scenario, what do you think? 3 months, 6 months, 12 months down the line, what's your anticipation of where people are going to be able to go to and be able to start kind of going through some of the requirements so that they can sit for this fellowship?
Well, right now, where we are is only the states that are actually have passed surgical laws that they can do that, with maybe an exception like Indiana, who was not prohibited and now are getting reimbursed by Medicare. They're just as much a surgical state as anybody else. So in a surgical state like that, if you would like to apply, just like you would apply to the academy, saying I'm going to do, I would like to show excellence in my field, and I'm proud of what I'm doing in the way of surgery. You can go on the website and apply. There may be, we're still talking about a few other things. Nate and I had a discussion the other day that we may be adding to that because it's early on. But I may mention a byproduct. We do not want there to be any thresholds of any future state. But I was talking to Cliff Cottle up in Kentucky, and he said that that's the way Kentucky was, that you had to do so many proctored procedures. And when you get locked in that legislative battle and you get locked in a room, you don't know what's going to come out of that room. And
Yep.
if there's other states that have that, and I hope they don't, but if they do, as we go from 12 states to 18 states to 24 states, I've got an active license, Chris, in Texas, Louisiana, and Iowa. Being credentialed like this, I could help Texas and I could help Iowa because I have a license there. And I've bet the number of procedures. So there'll be more people like me in other states that if that happened, they could cross over and help that. So it's not what Nate and I and Dr. Golden were all trying to do in the very beginning, but it may be a byproduct that helps out if it comes to that.
Yeah, and I say, like I
Yeah.
said, like John said, I view this as excellence. I view this as a sense of pride for the providers, the optometrists, and the profession for showing what they do, showing what we do, and it doesn't make anybody any better than anybody else. It provides a just again a feather in the cap, as we've said, and optometry should be proud of that, just like we're proud of FAAO, we're proud of FCOVD. Doctors do residencies. We're proud of that, and we're just proud as our profession is in general. So again, to me, I just keep coming back to recognizing excellence. It's what it's going to do is people to say, you know what, I do YAG caps, LPIs, SLTs, chalazion removals, eyelid procedures, whatever it is. And, I have been helping my patients for a long time, or maybe it's even just been a year or two in one of these recent states. And, I think it would be awesome and a sense of pride to have that FAAOMS to show the excellence that optometry does.
I don't think there's a better way to end it except to ask that once we get closer to some of these other things being more final, I'd love to have you guys back on, and just keep me in mind if there's anything you ever need, if from a communication standpoint or from other political action standpoint. I know that you guys aren't political, but anything that you ever need from me, I'm always here for you. So appreciate what you're doing.
Thanks, Chris. Appreciate what you're doing. Right back at you, buddy.
I appreciate it,
Thanks.
and I couldn't have summed it up any better than Nate did. It's just, excellence and care and pride of what we're doing.
Awesome. Thanks, guys.